Mr. Chairman, ladies and gentlemen, I'm here to address the issue about screening and detection of atrial fibrillation and obviously opportunities, or you could say missed opportunities for primary and secondary prevention. And just by way of introduction, just to say I have declarations of interest. If you missed this the first time round when I spoke just now, here they are again. Please be aware that in the context of what I'm about to say or speak in this lecture, please bear in mind I have declarations of interest as shown on this slide. So, in terms of looking for atrial fibrillation, well, I think this sums it up. Just keep looking, but don't forget stroke prevention. Because if we just accept the unequivocal fact that effective stroke prevention for atrial fibrillation with stroke risk factors really means the use of oral anticoagulation therapy, then you can focus on how to treat rather than who to treat, because ultimately stroke prevention is central to modern management of atrial fibrillation. And even one stroke risk factor confers real risk, not only of stroke, but also of mortality. And strokes associated with atrial fibrillation are more likely to be fatal, more likely to be disabling, more likely to be keeping the patient in hospital for longer. As mentioned, just keep looking and just keep looking, because the longer you look, the harder you look, you're going to find more atrial fibrillation. And that's not a new statement. This is a study from 2004 looking at patients presenting with an acute stroke or TIA. If you just do a standard ECG, look in terms of the proportion proportion where you can find atrial fibrillation. Just a standard ECG, you'll pick it up at about 6%. If you did a 24-hour Holter, you'll probably pick up atrial fibrillation at about 10%. But if you do a 7-day event loop recorder, you'll pick up atrial fibrillation ending up to 16, 17%. So the harder you look, the more likely you're going to find atrial fibrillation. And as I mentioned, this is not new news. Indeed, if you look into the literature, and this is a systematic review looking at cardiac monitoring for picking up atrial fibrillation or flutter after a presentation with an acute stroke, here are the different studies. That's the Javelin study that I showed on the previous slide. But rather than go through the detail of all these studies, you can see that screening consecutive patients presenting with an acute ischemic stroke with routine Holter monitoring will identify new AF patients, approximately 1 in 20. And I would strongly emphasize again, the longer you look for it, the more prolonged you have the monitoring, the more likely you're going to pick up the atrial fibrillation. I should just point out that we're not dealing with a homogeneous condition, because you find that the likelihood of picking up atrial fibrillation is greater if you have patients with certain comorbidities. And let me give you an example. This is the ECHOS epidemiological study that we performed in the West Midlands. And overall in the study, atrial fibrillation was found in 2%. No big surprises. You're going to find more atrial fibrillation with increasing age. That's not a big surprise. But look here in relation to the prevalence of atrial fibrillation in relation to different underlying comorbidities. You'll find that the greatest likelihood of picking up atrial fibrillation is among those with heart failure. And of course, you have patients with cardiac ischemia, myocardial infarction or angina, and obviously hypertension, diabetes, etc. So you will find atrial fibrillation more likely if you focus on some of the high-risk categories of patients, especially that of heart failure, also post-myocardial infarction. But this, again, is not new news. The harder you look, you're more likely to find it. If you screen for atrial fibrillation, you're more likely to get it, particularly amongst the elderly. And I direct your attention to this very nice systematic review from Ben Friedman and his group, where they were looking, they did a nice review looking at the prevalence of atrial fibrillation. And as you can see, it does depend a little bit on where you're looking for atrial fibrillation. If you're looking at all settings, you'll find that the prevalence of atrial fibrillation is about 2%. In the outpatient clinic here, in the general practice, you're talking about 3% and about 2% in the community. If you're focusing on those age over 65, there's no big surprise, you're going to find more atrial fibrillation. What perhaps is more worrying is that if you're looking at the proportion with previously unknown atrial fibrillation, in other words, emphasizing the point about missed opportunities, and focus again on the age over 65, you see about 1.5% of these patients you pick up, on screening, you will pick up these patients, previously unknown atrial fibrillation. And the fact that they're over 65, they already automatically have one stroke risk factor. So it's missed opportunities for stroke prevention by the fact that these patients are not previously picked up. And it's, in terms of picking up these patients, I stress the point again, we're dealing with a arrhythmia that gets more prevalent in the elderly. This is the, if you have limited resources, you're trying to direct your attention on who best to screen and who best to look for atrial fibrillation. Well, you see this age-dependent yield of picking up atrial fibrillation. And if I draw your attention firstly to figure 1 here, you will see that as the patient gets older, you're more likely to pick up both chronic or paroxysmal atrial fibrillation, and in those age over in the 80s or above, you've got to pick up atrial fibrillation, either permanent or paroxysmal, in anything up to 30–40% or even a bit higher. In a sense, if you, as mentioned, if you use more prolonged monitoring, as shown in figure 2 here, with increasing age, you're more likely to again pick up these patients. And some of the atrial fibrillation, some of the paroxysmal atrial fibrillation may well be detected in day 3 and day 4 of monitoring, especially in the elderly patients. But what is the trial evidence? What's the best way to screen and detect atrial fibrillation? Well, you can do opportunistic screening. In other words, those patients with associated comorbidities, they come and see you in the clinic, you make sure you take a pulse, and then if it's irregular, you confirm it with an ECG. Or, so it's opportunistic when they come in for the comorbidities. Otherwise, systematic screening is basically call up everybody and do an ECG. Well, what's the evidence? Well, there is the one trial only in the literature. This is coming from us in Birmingham. This is the SAFE trial, screening for atrial fibrillation in the elderly. And rather than take you through the detail, is basically we are picking up, as shown on the Laos systematic review, we're picking up atrial fibrillation in about new case detection in about 1.5%. In terms of which method is best? Well, opportunistic screening with pulse palpation and ECG was as effective as systematic screening, but as part of this study, we also did a cost-effectiveness analysis, and actually opportunistic screening turned out to be more cost-effective. But do note, this was a trial where the nurses and doctors were actually trained to pick up AF screening before the study. Now, whether this is rolled out and generalizable to rest, and do remember this study was done in about 2005, 2006, and technology has changed. In the Cochrane systematic review, it did identify the one cluster randomized trial, and that was the SAFE trial that I showed on the previous slide. And the Cochrane review reemphasizes what I just mentioned. Both systematic and opportunistic screening have a comparable effect on AF diagnosis. However, in terms of the cost effectiveness, well, opportunistic screening was more cost effective than systematic screening. But as mentioned again, how generalizable this to in terms of all healthcare systems. We were dealing with this in the UK National Health Service system, where the nurses and GPs were actually trained and to undertake such a trial. But we are in the era of new technologies. As I mentioned, SAFE, we conducted that in about coming up to about 10 years ago now. And new technologies, and this is, for example, a blood pressure monitor that can pick up atrial fibrillation. And just to say that this is one of the early studies that had looked at such a machine, a blood pressure machine that can pick up atrial fibrillation. If you have a patient with hypertension and they at least check their blood pressure every day, the sensitivity was 99%, the specificity was 92% for detecting atrial fibrillation. So the new technologies, including those in blood pressure machines, have the capability to pick up atrial fibrillation, and given that hypertension is one of the more prevalent comorbidities associated with atrial fibrillation, I think that's a very important group of patients to target. Nowadays, most of us have smartphones, and smartphones now have the capability to have little attachments. This is shown up here. This is the Alive Core Heart Monitor. And this is from Australia. This is Ben Friedman's group again that did a study in pharmacies, about 1,000 pharmacy customers aged over 65. They had newly identified atrial fibrillation 1.5%, and this is again consistent with some of the literature I showed earlier, rather from the systematic review or rather from the SAFE study. And all these patients, this 1.5%, all had a CHA2DS2-VASc score of 2 and above. Overall atrial fibrillation prevalence actually in this group of patients, Asia was 65, was 6.7%. But what is worth pointing out is the sensitivity and specificity is actually very high, and when they did the cost-effectiveness analysis for such a screening exercise, as well as picking up the patients with newly diagnosed atrial fibrillation, all of whom had high risk and needed anticoagulation, it was cost-effective, it was also feasible, because this is literally such a simple thing. Get a patient to hold these two electrodes, and then you see this ECG appearing, and then that can be transmitted either by Bluetooth or wireless to one of the desktop computers. But why the effort to screen atrial fibrillation? Why the effort to look for atrial fibrillation? Obviously, it's the missed opportunities for stroke prevention that I'm emphasizing. Can I stress the point that the fact that the patient is asymptomatic, it doesn't mean their prognosis is better. Well, actually, contrary to that, I'll start off by showing this analysis, this post-hoc analysis from the AFIB trial. But what it did suggest is the patients who are asymptomatic, they didn't really do any much better than the symptomatic patient. And just to say, more contemporary studies even suggest that the asymptomatic patients are even likely to do worse. This is a study we did from the Belgrade AF study, where, as you can see in terms of prognosis, this is for looking at ischemic stroke, you see that asymptomatic patients with atrial fibrillation did worse than the patients who were symptomatic. So in other words, very often the fact that they're asymptomatic, they're not seeking medical attention, they're not having the atrial fibrillation detected, they're not offered stroke prevention, and rather sadly, they present for the very first time with their AF diagnosis in the setting of an acute ischemic stroke. But nowadays, we're also in new technologies, and just to say that we now, many of the devices, whether pacemakers, ICDs, or CRTs, can easily pick up atrial fibrillation. There are many studies that have looked at this, and just to say that the prevalence of atrial fibrillation is considerable amongst these patients. Remember that if the mere fact that they've required, for example, a CRT, it's pretty likely that there's a patient with left ventricular dysfunction and silent AF is detected. And silent AF does increase the risk of thromboembolism. What is perhaps less certain is what is the actual AF burden threshold that confers this increased thromboembolic risk. It's not precisely defined. In relation to the technology, it's certainly the current position documents suggest that 6 minutes or more confers thromboembolic risk, but I would counter that by saying, let's say you have a monitoring period, you could pick up 6 minutes of atrial fibrillation. Who's to tell you that in the next monitoring period, you're not going to pick up 6 hours of atrial fibrillation or 6 days of atrial fibrillation? Ultimately, I would suggest that you approach this by looking at risk factors, and the fact that they have multiple risk factors, one or more risk factors, and almost certainly a CHA2DS2-VASc score 2 and above in a setting of any atrial fibrillation, I would give consideration to stroke prevention. This is illustrated in the guidelines. This is the ESC guideline algorithm, but basically it starts off by trying to make sure that you pick out your low-risk patients. Your low-risk patients are CHA2DS2-VASc score 0 in men or CHA2DS2-VASc score 1 in females. They are low risk. These are the patients who don't need antithrombotic therapy. Subsequent to that step, a patient with one or more stroke risk factors should be offered effective stroke prevention. And I make the point again, effective stroke prevention means oral anticoagulation. And these days, whether it's a NOAC or a vitamin K antagonist with a high TTR, a TTR above 70%. But I'll leave you with an interesting thought. I made the point before that if you look at patients with risk factors, and you look hard enough, you might pick up atrial fibrillation. And this is a post-hoc analysis from the TREND study where you look at patients with multiple risk factors at baseline, and they were followed up over the next year. What this interesting post-hoc analysis found was that atrial fibrillation, previously undiagnosed atrial fibrillation, was picked up in 1 in 3 of these subjects. So the fact that they have multiple risk factors by, say, the CHADS or CHADS-VAS score, if you follow them up long enough, over a year, 1 in 3, you will pick up newly diagnosed atrial fibrillation. And that has major implications. The fact that they already have multiple risk factors, should they develop atrial fibrillation, you pick it up. These patients may or could present with a fatal and devastating and disabling stroke. So in conclusion, Mr. Chairman, ladies and gentlemen, in terms of screening and detection of atrial fibrillation, the stress is on opportunities for primary and secondary prevention. The prevalence of atrial fibrillation is increasing. It is a major public health burden. The number of AF episodes per day as well as AF burden can vary, and paroxysms are frequently asymptomatic. But the fact that they're asymptomatic doesn't mean that the prognosis is any better. If contrary to that, some of the more recent data suggests even asymptomatic patients with AF do worse. What is perhaps less clear is how much duration of the arrhythmia which is required to precipitate a stroke or thromboembolism. But the bottom line is clear. Screening for atrial fibrillation will pick up more atrial fibrillation the harder you look. Opportunistic screening may be cost-effective, but ultimately with new technologies, systematic screening may well certainly be cost-effective too. Just keep looking, you'll pick up your more atrial fibrillation. Thank you for your attention.